good evening, everybody. Now, this is live webinar, Phacoemulcification in different situation. It is a joint webinar of All India Ophthalmological Society and Ophthalmological Society of Bangladesh, and organized by Bangladesh Ophthalmic Research Forum. It is my privilege to introduce our honorable chairperson and panelist of this webinar. First, I like to introduce today's chairperson, Professor Mohammad Sharfuddin Ahmed, Professor and Chairman, Department of Community Ophthalmology, Bangladesh Sheikh Mujib Medical University, and he is the President of Ophthalmological Society of Bangladesh. And he also President Bangladesh Community Ophthalmological Society and President Bangladesh Oculoplastic Surgeon Society. And he was the first Secretary General of Bangladesh Medical Association. He will chair the today's session. Now, I'd like to introduce our honorable panelist, Professor Abha Hussain, Director cum Chief Consultant, OSB Eye Hospital, and he is President-elect Asia Pacific Academy of Ophthalmology, and he was the past President of SAARC Academy of Ophthalmology as well as Ophthalmological Society of Bangladesh, and he was the founder President of Bangladesh Community Ophthalmological Society. Now, I'd like to introduce Professor Dr. Mahipal Singh Shashidhar, and he is one of the pioneers of phacoemulcification procedure in India, and he is the co-author of a practical guide to phacoemulcification, the first Indian book on these topics, and he is the chairman of Center for Sight, a chain hospital in India. The government of India awarded him civilian honor of Padma Shri in 2007. Now, Professor Din Muhammad Nurul Haq, he is the pioneer of phacoemulcification procedure in Bangladesh, and he is the chairman Din Muhammad Eye Hospital and Research Center. He was former Director General of Health Services of Bangladesh, and he was the past President of Ophthalmological Society of Bangladesh, Bangladesh Academy of Ophthalmology, and Bangladesh Community Ophthalmological Society. Now, Professor Mohammad Hazrat Ali, he is Senior Consultant, Cataract and Medical Retina, Harun Eye Foundation, and he is holding President, Bangladesh Academy of Ophthalmology, and also Vice President of Ophthalmological Society of Bangladesh. Now, it is my privilege to introduce Dr. Shams Muhammad Naman, today's moderator. Shams Muhammad Naman is now working in CITC as an associate professor cum senior consultant, and he is chief of glaucoma department, and he is the founder secretary of Bangladesh Ophthalmic Research Forum. He is general secretary of Ophthalmological Society of Bangladesh, Chattogram, and he is one of the director of General Eye Care Center. Now, may I request Dr. Shams Muhammad Naman to introduce honorable speakers and continue the session of this live webinar. Thank you very much. Thank you, everybody. Assalamu alaikum.
Yes.
Thank you.
Noman, you start.
Yes, sir. Okay.
You will introduce also Kader
Yes.
as a moderator
Yes.
and then other
Yes, sir.
speakers.
Yes, sir. Honorable panelists, honorable chairman, and honorable speakers. It's my pleasure to introduce all the panelists in this live webinar of phacoemulcification in different situations organized by Ophthalmological Society of Bangladesh and All India Ophthalmological Society, organized by Bangladesh Ophthalmic Research Forum. It's my privilege to introduce our honorable speaker, for whom we have built an academic bondage between the Bangladesh and India. So it's my privilege to introduce our speakers, honorable speakers, Professor Mohipal S. Sajdev. Is the Professor Mohipal S. Sajdev, Chairman, Medical Director of Center for Sight, President of All India Ophthalmological Society. He was honored with Padma Shri Award on January 26, 2007. India 2017 has attained professorship in ophthalmology. He is a renowned ophthalmic surgeon who is recognized for his expertise in the area of corneal, refractive, and cataract surgery, both nationally and internationally. Professor Sajdev has received numerous awards and distinctions in India and abroad for his contribution to the ophthalmology. He has been recognized globally with fellowship and scholarship from the 5th International Symposium on Immunopathology, Japan, International Society of Eye Research, Research to Prevent Blindness, New York, Vision awarded by the Contact Lens Association of the Ophthalmologists USA, amongst others. In India, he has won the Eural Memorial Trophy, Colonel Rangachari Certificate, Krishna Sohan Singh Trophy, Dr. Ishwar Chandra Silver Jubilee Award. Professor Mohipal has also received Lifetime Achievement Award in Ophthalmology at Times Healthcare Achievers Program held in Delhi. To add on, Professor Mohipal was honored with a gold medal in Coscon Conference 2017 in Bangalore. He was ensured that the Indian flag remains flying high in the domain of eye care with his mission statement, "Every eye deserves the best." And next, Professor Namrata Sharma. He is Professor of Ophthalmology, All India Institute of Medical Science, New Delhi, India. And he is also Honorary General Secretary of All India Ophthalmological Society. He completed his fellowship from the Moorfields Eye Hospital, London, United Kingdom. He is the Honorary General Secretary, what I have already told, All India Ophthalmological Society. He is the Regional Secretary of Asia Pacific Academy of Ophthalmology. He has received a lot of international awards, among few I am telling. Senior Achievement of American Academy of Ophthalmology, International Ophthalmologist Education Award, American Academy of Ophthalmology, Best Video Awards by the European Society of Cataract and Refractive Surgeon, RANSCO, and Best Show Awards 6 times by the American Academy of Ophthalmology. She also achieved the APAO Leadership Award, Achievement Award from the APAO. She has more than 450 publications in international peer-reviewed journals, has authored 11 books. She conducted instruction courses at several international and national platforms, and she is the principal investigator in many multicentric international FDA trials and RCTs, while have changed the clinical practice. And I'm really feel dignified to introduce in front of you Professor Partho Vishwas, is the Chairman Scientific Committee, All India Ophthalmological Society, and Director, BBI Foundation, India. What I have already mentioned is the Chairman, Education and Research Committee, All India Ophthalmological Society from 2017 to 2019. He initiated program Crusade Against Diabetic Blindness all over the India. He is a very high quality academician, eminent author and reviewer of national and international journals like Indian Journal of Ophthalmology and Ophthalmology from USA. Proud receiver of national and international award like Colonel Rangachari Award, ESCRS Best Paper Award, AIOS, Uveitis and Inflammation Best Paper Award, APCRS Video Award, and EOA Gold Medal. Recently, he has been selected as Chairman Scientific Committee of All India Ophthalmological Society. Congratulations, Partho Vishwas, sir. Now I am going to introduce my teacher, my respected teacher, Professor Jalal Ahmed, Professor, Director, Bangladesh Eye Hospital and Institute. He was the former Director, National Institute of Ophthalmology, former principal, Khulna Medical College and Hospital, former professor and head of the Department of Cataract, National Institute of Ophthalmology and Hospital. He is an excellent academician and keen phacosurgeon. He has achieved a lot of awards, he has many publications, and he has an experience to be invited as an invited speakers in different conferences, national and international conferences. And it's my privilege to introduce Professor Abdul Kadir as a moderator. He is the Secretary General of Ophthalmological Society of Bangladesh and head of the Department of Cornea, National Institute of Ophthalmology and Hospital. And this is myself with you in this program. So it's our immense pleasure to have you with us. Welcome to the session.
Okay.
So now I am requesting.
Yes. Noman,
Yes.
as the speaker, first speaker was Mohibal Sajdev. She will join later on. So
Yes.
we'll start with our speakers. Firstly, Dr. Jalal Ahmed, then Partho Biswas, then Namrata Sharma, and then Mohibal Sajdev.
Yes,
I
sir.
think I welcome all the speakers and panelists here, and we will start our session just now, and it will be announced by our moderator, Dr. Shams Mohammad Noman, the first speaker. Noman, you start.
Yes, I am requesting respected Professor Jalal Ahmed sir to start the session.
Okay.
This first speech. The topic is phacosurgery in the white cataract. Thank you, sir. The time is yours.
We all can mute ourselves. We all should mute ourselves, and then we will take after making unmute.
Okay. Can you see the? Can you see that presentation? Okay.
You will start your screen share. Not yet started.
Not yet started.
Yes. Yes. Yes, Jalal. Now we are in the screen.
Whether I am busy, my screen is visible.
Yes.
Yes, sir.
Yes.
Okay.
Yes, it is visible.
Assalamu alaikum and a very good evening. Mr. President of OSB and AIS, Professor Mohammad Shakuddin Ahmed and Professor Mohibal
I can't see. Everybody is visible except me.
Yes,
Can
you are visible, ma'am.
But I can't see. Only Zoom.
No, ma'am, you can see yourself now. No problem. Because skin is sharing. That's why. No problem.
Whether I am audible? Whether I am audible?
Yes, sir.
Yes,
You
sir.
can continue,
Yes, sir.
sir.
You can continue, sir. Yes,
Okay.
sir. All things okay. You can continue.
I can hear,
Yeah.
but I can't see. Okay.
Mr. President, Professor Mohibal Ahmed and Professor Mohibal Sajdev, the Secretary General, Professor Abba Hossain, President-elect of APAO, and my teacher, Professor Abdul Kadir and Professor Namrata Sharma, Secretary General of OSB and AIOS, Professor Tin Mohammad Nurul Haq, the past DG and former Director General and past President of OSB, Professor Muhammad Hasrat Ali, and Professor Partho Biswas, is Chairman Scientific Committee AIOS, and Dr. Shams Mohammad Noman, the moderator. Welcome everyone. My topic is management of white cataract. White cataract is a common scenario in this part of the world, and more so it is common in the remotest part of these countries. And I have no financial interest there are many type of white cataract. It looks white, but behind the white there may be white, there may be black, there may be brown, the zonal may be weak, there may be subluxation of the lens, and so many. So before management, we have to evaluate the case, each case separately. In C-lamp, we have to see the whether what is the type of the cataract, what is the anterior chamber depth, and anterior capsule is whether it is bulging or not. Is there any capsule wrinkling, fibrosis, scarring or calcification of the capsule? Is there any zonal adhesion? Whether the cortex is liquefied or the cortex is formed, and the pronation central nucleus, whether it is visible or not, and whether is there any secondary association like glaucoma, it is associated with glaucoma, whether it is associated with severe exfoliation, uveitis, diabetes mellitus, and in biometry by IOL Master and other machines, we can see the lens thickness, whether the thickness of the lens is more than 5.25 millimeter. Is there any posterior segment anomaly? We can charge by using doing P-scan ultrasonogram, and we should see the pupillary response also. And before managing the white cataract, counseling is mandatory regarding the process of tackling the problem, the perioperative complication, and the final visual outcome regarding this. The counseling is mandatory. And there are many challenges, but some of the common challenges in white cataract are there is absent red reflex, poor visibility of the rexis margin, difficult nuclear depth assessment, capsule may be thin, it may be fragile or fibrotic, there is high interlenticular pressure, there is greater risk of rexis runout, incident, vitreous loss, or lens nucleus dropout. And there are many ways, many surgeons are overcoming these problems by their own way, but there are some common way of tackling these problems, like that staining of the capsule using high molecular weight viscoelastic substances, maintaining good anterior chamber depth so that anterior capsule always remain flat. And anterior chamber pressure is more than the interlenticular pressure, and not targeting a too big rexis and use it of forceps. And here is a video clip showing the rexis in a white hypermature integration cataract. I am just initially I use a spatula to press the liquefied lens material in periphery. First I targeted a small rexis and complete the rexis, and then the nuclear the lens material liquefied cortical matter is aspirated, and second in the capsule margin a snip with scissor is given, and a bigger rexis is targeted, and it completed nicely with no problem. This is the one of the common and easiest way of doing, that is double rexis. There are many other ways of doing rexis. There is another way of doing rexis is orange peeling like rexis. Initially, after puncturing the capsule, we attempt a smaller rexis, and nearing the near about completion of the rexis, we targeted a bigger circle and completed as our targeted diameter of the rexis. So it is also an easy way of completing rexis in white cataract. It is also a good way. And there are many other ways. Many surgeons are trying in many different ways, and every surgeon has their own way of tackling this rexis. Here is two more video clip showing the rexis in left one is a more white one, and right one is a dense nucleus. But the rexis, we can complete the rexis by using high viscoelastic substances and completing the rexis in a careful way. So rexis, if we can complete the rexis, then the management becomes more easier. And another good way of doing rexis is using femtosecond laser. The femtosecond laser works in a closed chamber, and it is, if it is affordable and available, then we can use femtosecond laser, and it is a good way of tackling the rexis problem in hypermature cataract. By using the femtosecond laser, if there is a small tag, in some of the cases, a small tag may remain attached, but it is very easy to remove that capsule and complete the capsule in a very good way. And also by using femtosecond laser, in white cataract we can manage the nucleus in a pretty good way. Nucleus requirement is very much less by using femtosecond laser. In here, there is another video. Even with all precaution, sometimes capsule may run out. When I enter the anterior chamber pressure becomes very low, and as soon as we puncture the anterior capsule with high interventricular pressure, the gushes of fluid from behind the lens just rushes through a small puncture and they turn the rexis in a radial way and forms the Argentinian plug sign. This may happen in some of the cases, so we should be ready for tackling this. Another problem occur during rexis, that is the fibrous capsule. In case of fibrous capsule, we can do the rexis in a different way. We should be careful, and in these cases, some of the cases may require the use of scissors. By using scissor, we can complete the rexis also in fibrous capsule cases. This is also another case showing hard cataract with fibrous capsule, calcified capsule, and we complete the rexis with using some scissors. With available a smaller scissor should be, but this scissor was a bigger one, so we can complete the rexis in these cases. If we can complete the rexis, here how then after completing the rexis we have to manage the nucleus. If the nucleus is soft, it is not a problem at all. By using only vacuum, by using no power, we can complete the we can clean the bag and we can remove the cortical matter and we can complete the bag. So in case of very soft nucleus, in some of the hard cases, the nucleus is like that, too much soft. But in hard cases, we have to use different technique. In this case, I am just doing a deeper, using a vertical chopping, complete separation of each segment. So complete separation of each of the segment. During complete separation of this segment, we have to just separate the lens by holding it in its posterior one third, not in the superficial part. So we can complete by using vertical chopping, then using judicious use of power, appropriate use of vacuum, and frequent use of viscoelastic substances, we can complete the hard nucleus without mass, without any complication. So this was a hard nucleus, and then this is the second postoperative day appearance of the cornea in that hard case. If in case of traumatic cataract, we have to assess the case before doing surgery. Sometimes total assessment may not be possible. In this case, we can see that there was rupture of the anterior capsule, but luckily the posterior capsule was intact. We just aspirate the cortical matter, and then intraocular lens was possible to be given into the bag. So in some of the cases where the capsule is intact, no problem of giving intraocular lens after complete the surgery. In case of Morganian cataract, the problem is nucleus is smaller and nucleus just to and fro moves through into the anterior capsule, into the bag, capsular bag. So the technique is we have to use vacuum, sufficient vacuum to hold each fragment. We try to separate the fragment completely, and frequent use of viscoelastics and with use of power, we can just prevent corneal damage by frequent movement of the fragments. Here, even in compromised rexis, the left side case there is Argentinian plug sign, and the right side also you can see that in both cases, in left side there is Argentinian plug, and in right side there is also a capsular radial extension of the capsule. In both cases, phacoemulcification is possible. In that case, we just carefully we do the phaco away from the radial extension area. So it is possible in a good way to complete the phacoemulcification. And big complication. Next step, surgeon cannot complete the surgery with foot, then we can use SICS. And by using SICS, we can give good vision to the patient, even we using PMMA lens, only hard lens. By using hard lens, we can even give good vision to the patient, even after to tackle the severe complication. So our take-home message should be ready for any surprise in case of white cataract. Have patience, use appropriate technique, proper instrumentation and tools, and best possible visual outcome can be given to our patient with white cataract. And thank you all for your kind attention. Thank you everyone.
Jalal, thank you very much, Jalal, for your nice presentation about the white cataract. I want to ask our panelists that whether we will discuss later on or after each speaker. If after each speaker, we can just discuss now. And I think if all the speakers will present, and later on the question answer and the comment from the panelists, that can be done.
Sir, Professor Mohipal Sajdev is with us. Sir,
Yes.
sir, welcome to the session, sir.
Welcome.
Good evening,
Sir Mohipal Sajdev.
Good evening.
Okay.
Good evening,
Thank
sir.
you. Welcome.
Welcome, sir.
So,
apologies for slightly late. Actually, I didn't realize it was Bangladesh time, not India time. Sorry.
Some also informed us that you will come a bit later.
Yeah.
we had already informed that he will come later.
So I am requesting Professor Parthobishwas sir to start his speech on phacoemulcification in the loose tubules. Parthobishwas sir, now the time is yours. Thank you, sir.
Good evening, everybody. And it's a great privilege to be here this evening along with our own team from India, Professor Maipal and Professor Namrata. And I'm so happy to be again with all of you. And I'm extremely grateful to Professor Mohammed Sharfuddin Ahmed sir, Professor Abba Hussain Madam, Professor Dean Mohammed Nurul Haq sir, and of course to Professor Jalal, whose talk was excellent, and of course Professor Mohammed Abdul Qadir, and the most and the best person who organized and took all the pains was none other than Dr. Shams. So thank you everybody, and I would like to discuss a few nuances of phacoemulcification and compromise sonules or loose sonules. So these are patients in which we have difficulties, we know the level of difficulties, and the level of difficulties is not always known when the patient is in the outdoor and we are examining him or her on the slit lamp or on the different diagnostic equipment that we have. So subluxation and dislocation, and both these aspects are related to weak zonules or compromised zonules. So this subluxation or dislocation, whatever the patient may present with, the etiology can be congenital, it can be acquired. In congenital, it can be atopic lentis, and atopic lentis pupillary, hereditary atopic lentis. In acquired, it can be trauma, weak zonules, encephalitis, RE, syphilis, ophthalmus, and severe or pathological myopia or ciliary body tumor. And the list is quite a long one. And the systemic disorders one needs to keep in mind, and they can be Marfan syndrome, it can be homocystinuria, Wilmer-Shesani, Rieger's anomaly, Ehlers-Danlos, hyperglycemia, sulfite oxidase deficiency, Sturge-Weber's, or craniostosis. So whenever a patient comes to us, and this we have studied in our postgraduate days, superotemporal luxation, most commonly Marfan's, inferior subluxation, most commonly homocystinuria. But these associated anomalies can range, and they are important because they can be associated with other symptoms. The workup is very important, and a whole history as well as a family history and an assessment of skeletal problems have also been able to be taken. The ocular examination is important because of the difference in etiology, and this needs to be done in a detail and to be noted down and documented. The choice of the surgical procedure, and here I would like to express that a CTR is an important aspect, and I'll dwell on this slide for a minute. And the first choice, if it is a CTR with IOL implantation in a superior dislocation, subluxation up to 4 clock hours. The second choice is an IOL implantation with the haptic being used to stretch the back. The inferior up to 3 clock hours CTR with IOL implantation, and anywhere between 3 and 6 clock hours of subluxation modified CTR with a single loop. Anywhere greater than 6 to 9 clock hours modified CTR with the double loop with IOL implantation. 9 or more clock hours with general weakness of the zonules, intracapsular cataract extraction, sterile fixated or iris fixated, and tear-chamber IOL or a blue IOL is what is done. Flax and subluxated cataract, and flax offers great advantages because of it does not depend upon the zonular support, and the counter resistance is not a limiting factor in these patients. Let's look at a few videos, and I will share with you these videos. And this is a video in which we have quite a dense dentina capsule, and as you can see, and there is a lot of fluffy white cortex, and there is a high intralenticular pressure, and we go step by step trying to remove the intralenticular pressure, decrease the intralenticular pressure, and then go ahead with the cystosome to complete the rhexis. However, in these cases, the microforceps from the side pole is a great advantage, and a rhexis can easily be complete. Now, in this case, I feel that we need to put a CTR in right at the beginning, knowing the difficulties that might be there as the surgery goes on. So we place the CTR in, and then take out the fluffy cortical matter, which is more difficult. It's a very soft nucleus, but remembering every time that we need to inject the viscoelastic in the bag before taking out the side port. And this we do, and then gradually removal of the cortical matter, which has to be done. And this is where the cortical matter might get combined with the CTR and might have caused a drag on the CTR. So a tangential removal of the cortex is what is important. And if this is done carefully, we will not increase the amount of subluxation for these cataract lenses. And you can do a little bit of polishing. You can, and if the rhexis is a small one, you can even increase the size of the rhexis. Here we place the intraocular lens, a single piece intraocular lens in the bag. And since this is less than 3 clock hours of subluxation, the stability of the IOL, centration of the IOL is well maintained without the use of any device. Let's look into another situation where we have nearly 270 degrees of subluxation, and we have a little bit of trouble with the CTR. And I'm going to show you that removal of the CTR might give trouble at different times. So here, as you can see, I've started the rhexis in an opposite quadrant than the quadrant of subluxation, and I'm taking it up with the cystotome is the time that we intend to put the CTR in. Now look at this. The CTR goes in smoothly, not so smoothly, and it has slipped and has gone into the angle of the anterior chamber. So I'm trying it once again, and as you can see, there's a large amount of subluxation, and look what happens. The CTR actually twirls round and goes and anchors itself on the stem of the sideboard instrument. So again, it slips out. So we have the CTR slipping out once again. And why is this happening is what I'm going to explain a little later. So we go ahead with the second instrument from the other sideboard, and this time I think I'll have a little more luck, but not really. Again, it's a little difficult here, and it's going ahead and it's slipping out all the time. Why is this happening? Look, it's gone into the stem of the instrument once again, and this was called the valve. So we could, after all, get the CTR in its position. And then, of course, the next part is removal of the nucleus management, which is important because the nucleus is quite widely subluxated, and we chop it into small pieces, removing one piece after the other, keeping a good view of the anterior chamber, being very watchful if any vitreous comes in. If at any time vitreous comes in, the next step has to be vitrectomy, and only after a good vitrectomy, again, nucleus management can be done. Here we are lucky and fortunate, so placing in viscoelastic in the capsular bag, so you can see it's quite very stable, removing out the cortical matter, and then this becomes quite easy and is quite well centered. Let's go on to the next video, and here this is a very favorite video of mine, and we call this patient Bhuvan, and we made a film of this video and it won awards. And here is the patient, and when the patient first comes to us, I've just stopped the video, paused it, and when the patient first comes to us, he presents with this huge amount of trauma, and the patient, the cornea is slit right from end to end nearly, and what we have is this patient with a lot of trauma, and the iris is popping out, and we do a primary repair in this patient, and we do an ultrasound, and the ultrasound shows that possibly there is intraocular foreign body, and we are quite hopeful that this has to be a two-stage or maybe a three-stage surgery, primary repair, and 4 months later, the intraocular foreign body disappears. It's not disappearance, because it was an artifact in the first instance. So we have a case of traumatic aniridia. You can see just a little bit of the iris there, the rest of the iris is gone. So we ventured to the cataract, and the cataract has changed. It's quite remarkable. The patient has lost vision. So we do a capsular rexless and very gentle hydrodissection and hydrodelamination, and we at every point of time we know that things might go wrong, things might go difficult, and we're trying to see if the nucleus will rotate. It does rotate, and we put in the CTR for the stability of the capsular bag. So once the capsular bag is more stable, rotation is also better, and we do a straight chop for the nucleus management. Every time we remove the instruments from the eye, we need to put in high molecular weight viscoelastic time and again, and to maintain the anterior chamber to the best of our abilities. At this point of time, I fear that I'm possibly ruptured posterior capsular, there is an existing posterior capsular rupture. Therefore, I'm leaving that little bit of pie of the nucleus in place, and I'm trying to put in the intraocular lens before the bag fully goes away. But very fortunately, actually the bag was not ruptured, and I could remove the last bit of the cortical matter. But then now comes the next important step, is the reconstruction of the iris by the iris rings. The reconstruction, and these are indigenous Indian-made rings, which we are going to use, and they go right into the capsular bag. These are two rings which need to be placed one after the other, and all in the bag. So the bag is holding the CTR, it's holding the lens, and it's holding these two iris reconstruction rings. So one by one they are placed, and these rings have to slide over each each other and to occupy a space in between themselves so that the iris reconstruction can take place. And all this, remembering the fact that this was a subluxated lens, but the subluxation was not much and it held on. So we removed the cortical matter, we removed the viscoelastic. And why I wanted to show this video specifically was this video is nearly 7 years old and we've been following up Mr. Bhuvan for the last 7 years now, and it remains the iris reconstruction rings remain intact, and we are really grateful to our Indian manufacturers who make such good quality rings and which are not very expensive as well. So let's go into this subluxated cataract, and it's a grade 5 nucleus, and I'm going to have trouble here as well. So let's look at this cataract. As you can see, it's a grade 5 cataract, half popping into the anterior chamber, and I have to place in the hypothetical viscoelastic in the anterior chamber before the trimine blue smearing. So I smeared the trimine blue on the anterior capsule, which has to be very patiently done, otherwise the staining can take place. And the next step, of course, is making a capsule rexis, and if the capsule rexis can be made well, then room is half one. So it is important to have a capsule rexis in place, and of course, because of the large subluxation, we need to put in the iris. We need to put in the capsular hooks. The capsular hooks, as you can see, are very adramatic and can hold these capsules nicely in place, and then placing the CTR and so that the luxation is as much as possible in control. With the capsular hooks and the CTR in place, phacoemulcification becomes quite easy, and we are able to do a gentle hydrodissection. As you can see that the subluxated lens, which was half nearly into the anterior chamber, has settled to an extent. And now what we have is this grade 5 nucleus has to be managed. We try and straight direct troponin. As you can see that it has to be a multi-component dissection so that we can go in depth by depth and eye fiber by fiber. You can see that it is clearing up, it's cracking from the periphery, and the crack to the center is the most difficult part. So we carve out small pies of these of this grade 5 cataract so that these small pies can be eaten away, more spaces possible, and replacing by high molecular weight viscoelastic, we are able to retain the integrity of the capsule as well as unharmed corneal endothelium as much as possible. And then is the next part, and that is placing the intraocular lens in the bag. So we choose a single piece intraocular lens, and this is placed in the bag. Since you can see the large amount of subluxation, we'll have to put in a segment, we'll have to put in a device to anchor the subluxated bag. So we go ahead and we make a small pocket. The sclera, we could have made a Hoffman pocket as well. And here I would like to pause the video and tell you about the level of difficulty that I had in this case. So as we were, can you see this segment that it is? It does seem to be a little unnaturally large, doesn't it? So is it an ambient segment? Is it a Sioni segment? Well, actually, it is not. So let me tell you this part of the story that happened in the operation theater while I was doing this, and I've just paused the video to tell you the extent of this. So what had happened is I asked the theater nurse for the segment, the ambient segment, which was what was required here. And after a minute, she said that she had dropped it on the floor. And then I said, the next one, please. And she said that she did not have. And then she said after a while that she had a broken Sioni ring. So a broken Sioni ring was there, and she said that she had ETO'd it and had kept it. Could I use it? So I thought to myself, I could. And what immediately struck me that this broken ring would have a jagged piece would have a jagged part at the where it had where it was broken. So I need to do something about the jagged end. So there, what I did is I cauterized that jagged end. So with that cautery, I was at least a little sure maybe it would not rupture the posterior capsule or the anterior capsule while placing it in. So I restart the video, and this is where I'm taking a lot of care to place this broken ring as atraumatically as possible, and God willing, it goes in and it stays in place. So we have the ring, and we are able to anchor the ring, and the subluxation is well cared for, becomes nearly central, and we are able to maintain the integrity of the capsule bag. So at times, when these things happen, one has to think out of the box, and God actually comes to your help at such times as well. So let's go on to the next video, and this is a video of very, very loose news, and this again is a very favorite video which won quite a few awards. I will go to the second part of the video, and this is the part that I would like to dwell with. So this is spherophagia, Phacoemulcification syndrome, and this is what we have here. So it's a young girl, and with spherophagia half nearly popping out into the anterior chamber, and I'm aware that I'll have to deal with very, very loose needles. And in the first eye of this patient, we had a lot of trouble, and I wish I had some time to show you because it's a little longish video. But we'll go to the second eye, and this is the spherophagic bag that we have, and you can see that it is like a deflated balloon, and I'm having trouble just entering into the capsule. So I'm using a sideboard cut spatula to enter the anterior capsule, puncture the anterior capsule, and then finally going around with the microforceps using the sideboard instrument as for the counter traction. After that, it's relatively simple. The difficult part is making the lenses, the intraocular lens, and we place it right inside the bag. And as you can see, it's a small bag, and you can see the folding of the haptics right inside. And what we have done is we are holding the bag with the iris hooks. We could have used the capsular hooks as well, but the iris hooks is what we used, and that's because of the smallness of the hook that we take this into aspect, and then we anchor it with two hammered segments, and well anchored, the eyes of this patient, the eyes are well centered IOL and in the back, and patient regains back 612 and 8 vision from very poor vision up to complete. This patient did not have glaucoma, and did not have to manage that part of the complication. So thank you very much for your very patient hearing. I'm really so glad to be with you, with every one of you this evening.
Thank you, Professor Partho Vishwas, for your very interesting and presentation, very nice videos. Everybody has enjoyed a lot. So in this session, I am requesting Professor Namrata Sharma, Professor of Ophthalmology, AIMS New Delhi, and Honorary General Secretary, All India Ophthalmological Society, to present his session. The session is cataract surgery in the compromised corneal haze. Professor Namrata Sharma, now the time is yours.
Thank you so much. It is always a pleasure to presenting a video at the Bangladesh platform, and I've been to Bangladesh at least a couple of times, and the hospitality which I have received is unparalleled. I would like to acknowledge that. Professor Muhammad Sharfuddin Ahmed, President of the Ophthalmological Society of Bangladesh, Professor Aba Hussain, who's been been a mentor to all of us and who's also the President-elect of Asia Pacific Academy of Ophthalmology. Our very own Professor Maipal Sachdev, who's the President of All India Ophthalmological Society, Professor Dean Mohammad Nurul Haq, Chairman Dean Mohammad Eye Hospital and Research Center, Professor Mohammad Hazrat Ali, President Bangladesh Academy of Ophthalmology, Dr. Partha Bishwas, again Chairman Scientific Committee AIOS. Excellent presentation by Dr. Jalal Ahmed. I think one of the best, you can say, collection of white cataract videos I have seen. Director of Bangladesh Eye Hospital and Institute, Professor Abdul Qadir, Secretary General of Ophthalmology Society of Bangladesh, and very dear Dr. Shams Noman, who's so dynamic, active, and who's organized this wonderful webinar. It's a pleasure and an honor to be presenting here today before all of you. And thank you for inviting me here. And I will be talking to you about an important subject, and that is cataract surgery in compromised corneas or in cases of corneal haze. Now, very much of this is what we actually do as an instruction course in the American Academy of Ophthalmology. And there are no financial or proprietary interests, and I would be discussing the off-label use of trypan blue dye as well as the air. Whenever you have a case of cataract surgery with a corneal opacity, the bigger question is whether will you do a cataract surgery alone or you will combine it with the corneal transplantation procedure. You can do any kind of cataract surgery. It could be SICS, it could be phaco. The important thing is that you should be well versed with it. The factors which determine whether you will do a single stage procedure or combined procedure are the type of corneal opacity or haze, location of haze, expertise of the surgeon, availability of the donor corneas, and visual requirement in terms of risk-benefit analysis. It is important to optimize the ocular surface with the lubricants, and sometimes when there is inflammation, even with the anti-inflammatory agents, which could be topical cyclosporin or loteprednol prior to the surgery. If you have a case of pterygium with phacoemulcification, then depending upon whether it is involving the visual axis or not, you may have to do a combined procedure or you may have to do a sequential procedure. If it's a small atrophic pterygium, you can leave it alone or maybe do it at the same sitting. But if the astigmatism is more than 2 diameters, extension is more than 2.2 millimeters, width is more than 5 millimeters, then in those cases, it is always good to do pterygium surgery first, followed by cataract surgery. Again, there's always the dilemma as to, in cases of fixed dystrophy with cataract, is to do a combined DSEC or DMEC triple procedure or to do a phacoemulcification alone. Now, when again you have Salzmann order degeneration such as this, or you have recurrent corneal erosions, it is always best to treat these pathologies first with the BTK, and then after 6 weeks plan when the keratometry stabilizes. Now, IOL power calculation is again a different ballgame, which I'll be talking to you later. And this is the algorithm that we follow. So if it's a small central corneal opacity partially covering the visual axis, you can do phaco alone. You can even combine it with optical iotectomy. But if it is involving only the superficial part of the cornea, then you can combine it with BTK. However, if the more depth of the cornea is involved, then you may have to do a SALC triple, that is superficial anterior lamellar keratoplasty with phaco and IOL, or you may have to do ALTK triple, automated lamellar therapeutic keratoplasty, or still deeper, a DALC triple, or endothelial keratoplasty with a triple procedure. And of course, if all the layers are involved, then a full thickness graft. This is a review article that we did for Journal of Cataract and Refractive Surgery, which summarizes, in fact, everything that I would be talking to you about. And we prefer to use in these cases the monofocal intraocular lens. The keratometry is generally taken as standard, and the biometry can be done with the help of ultrasonic B scan or can be done with the help of the motion scan. IOL master is often not possible in these cases because of the corneal haze. If there's a case of fixed dystrophy with cataract, then you have to look at the figures. So the magic figures are 650 microns into 800 cells. If there are no epithelial changes and if the corneal thickness is less than 650, cells are more than 1000, you can do phaco alone. But if there's poor view for phacoemulcification and thickness is more than 650, cells less than 800, then in those cases, you will have to plan a endothelial keratoplasty with the phacoemulcification procedure. These tips and tricks I would be showing as I go through the videos. So you have to plan your incision first. So suppose the corneal haze is on this side, so you have to plan in such a manner that at least one half of the cornea is clear. So you go in with a temporal incision here. Whereas if the opacity is like this, then here you will go in for a superior incision, because one half of the cornea has to be clear for you to do your phacoemulcification. This is a case of chemical injury with paracentral corneal opacity stained with the trypan blue dye. Just as you go underneath that haze, you have to do the capsular rhexis in one go, so that you don't lose that edge of the rhexis underneath the corneal haze, and you can just pick it up and complete it, and then complete your phacoemulcification as one would do normally. Important tip here is always put your retroillumination on, because once you do that, the orange glow gets better and you are able to see your grayish cortical matter or nuclear fragments underneath the orangish glow. And this is followed by a foldable intraocular lens implantation. This is just to show a case who didn't want to undergo a corneal transplantation procedure. Fixed dystrophy, you can see that there's a lot of widowing even on the intraop OCT microscope. It gets, when you do such cases when there's corneal haze, then all the steps get a little more clearer when you have intraop OCT microscope. But important thing to highlight here is that you should use a viscodispersive agent or OVD like the Viscode, and you use BSS plus as irrigating fluids so that the endothelial cells are protected during the surgery. This is a case of yield keratitis with cataract, which was almost grade 4 with optical iridotomy done. The patient didn't want a corneal transplantation procedure. And again, in this case, as you go underneath that corneal haze, you have to go in one go when you're doing a capsular rhexis. Do a little bit of glow manipulation so that you can see the edge of the rhexis there. Do a little eccentric rhexis so that the area from where the patient is going to see is opened up. And this is the area also for you to see where you do the phacoemulcification. Again, in this case, eccentric radar is being done, and don't forget to put the retroillumination on and do phaco-in-situ. That means drop, repeat, so that the orange glow gets better and better at all points in time. And as that gets better, the grayish or the nuclear fragments are seen in a much better manner against the orange glow. And sometimes you may have to camouflage, you may have to lollipop these because of the corneal opacity. These nuclear fragments are getting camouflaged underneath that haze, and you can see that the edge of the capsular rhexis is there, and then a foldable intraocular lens can be implanted in the back. So this was again a case which was planned actually for optical iridotomy, but just as this was done with the help of the projector, underneath the zonular cataract was present. Now these cases can be tricky because you don't know what power of the lens to put. So you have to plan your cases and anticipate that there would be a cataract which may be there, and then you plan preoperatively accordingly. So bimanual irrigation aspiration is being done here because this was a child, and this is subsequently followed by the foldable intraocular lens implantation. And as this is done, then one may even have to enlarge the pupil in the post-operative period because you want that the patient should be able to see from the area which has been enlarged. Sometimes what happens is you have to expand your area of visualization. For instance, in this case, the pupil is small, cataract is hard, so you have to expand your area of visualization by putting these nylon hooks, a temporal incision, eccentric radar, following all the steps that I had initially talked about in the initial case. All the tips and the tricks have to be followed. This is a case of chemical injury for which a penetrating keratoplasty has already been done. And sometimes you have this pannus in these cases. I'm sure chemical injuries are common in Bangladesh as well. So this pannus has to be removed. And just notice how cornea is clear beneath this pannus. And whenever it gets blurry, put that blob of viscoelastic. So it will be magnified for a little bit of time, for a split of a second, it will get even clearer, and at least allow you to initiate the step that you actually want to do. And then subsequently the step can be completed, and because the cornea is clear now, the surgery can be done as one would normally. Now this is a black and a white cornea. So it's a corneal opacity which somebody has tattooed, and again expand the area of visualization by using the nylon hooks, do a temporal incision, use capsular rhexis forceps. Sometimes when the edge of the rhexis gets lost underneath that case, you can actually pick it up from the intraop OCT microscope and the rexes, as well as the case again, put the retroillumination on and irrigation aspiration is then done. And notice once the glow gets better, it's actually not that bad. And then you can put the intraocular lens. Sometimes it's hazy, and in between the case, when a little bit of contact is still there, you can still put the lens. Because as soon as you put the lens, it gets better. The orange glow gets better and the visualization gets better. And here the pupil is being enlarged because otherwise the patient will not be able to see. And this is what I call the pilocarpine test in the end. You put the air bubble, put pilocarpine, and just see what is the area which actually you can see on the table and the patient will be able to see in the post-operative review. Now, this is just another paper of ours which looked at cases of Steven Johnson syndrome. These are high-risk cases for corneal transplantation. So again, you can see the pupil has been expanded, the incision is temporal, the endoilluminator is inside the anterior chamber, so that you can see where you are chopping, and now it is outside the anterior chamber, so that you can see where the intraocular lens is. So one has to resort to numerous aids for these cases, which are high risk for corneal transplants. And these are some of the results pre and post-op. So patient does become ambulatory with good visual acuity. Another one with a visual acuity which was initially counting fingers, now it goes to 6-12. Again, a very complicated case of PUK, patch graft done, Phaco done, and 618 the patient is seeing. Although the contrast is not going to be that good, but the patient is ambulatory. And again, this is yet another case, and yet another case because of the haze, the visual acuity is less. Now, what happens when you have a case like this, chemical injury, where you have to do deep anterior lamellar keratoplasty and then do corneal transplantation procedure? So this was a case of deep anterior lamellar keratoplasty, which was planned like that. We didn't plan a cataract surgery, and then as the layers were dissected, you realize that there's a cataract there. So the cataract with some stroma still there, the cataract surgery is done. You can't do cataract on a bare Descemet's membrane. So this is done as one would do normally, and this is subsequently followed by, whenever it gets blurry, this is intraocular lens implantation. Put viscoelastic, then wash away all the viscoelastic, and then put a donor cornea there so that you suture it with tension filament. And the sutures in the post-op is this with 6-12 visual acuity. Now this was a case which was referred for actually a full thickness penetrating keratoplasty, but then in this case 3 rexes have been done. So first the epitheliorexis is done, so the hypertrophic epithelium is removed. Then desmetorexis is done, which is a calcified Descemet's membrane because of fixed dystrophy. So this is the second rexis. Then anterior capsulorexis is done. So this is the anterior capsule of the lens. And then subsequently phacoemulcification is done, followed by a foldable intraocular lens implantation. And then a posterior lenticule is being Descemet's membrane stroma complex is then taken, put on the Brussels glide, and is then placed inside, and then the graft is placed in the anterior chamber, and air bubble is instilled so that it gets stuck to the back of the graft. And this is at 5 years follow-up with the visual acuity of 6-9. You didn't have to do a full thickness penetrating keratoplasty. And this is the last part of the video where you would like to do a DMEC triple. So a Descemet's membrane roll is being fashioned after staining it with a trypan blue dye. This is the most physiological graft that one can imagine. 8 millimeters trepanation is done. The peripheral part of the Descemet's membrane is removed. The central part of the Descemet's membrane is then taken, and this is the healthy Descemet's membrane. And when you have a patient with a diseased Descemet's membrane such as this, in the case of fixed dystrophy, where cataract surgery has already been done, so in this case, the diseased Descemet's membrane is removed. The healthy Descemet's membrane, which I showed you earlier, is taken inside the IOL cartridge injector, is placed inside the eye, which has got fixed dystrophy, from which the diseased Descemet's membrane has been removed, and then subsequently, when it is in the correct orientation, which is now, it is air bubble is instilled so that the healthy donor cornea gets stuck to the back of the cornea, back of the stromal lens. So now you can see that it is quite stuck. So this is at post-op day 1, and this is at post-op month 1. You can't even make out that there was ever a graft done. It's pretty much like a Phaco case. So whenever there is a case of phacoemulcification in corneal opacity, if it's a high risk for graft, then do a Phaco first and see how it goes. But if the prognosis for grafts is good, then you combined procedures with the corneal transplantation. So thank you very much for your kind attention, and if there are any questions, I will be happy to answer.
Yes. And Noman?
Thank you, Professor Namrata Sharma, for your excellent presentations and also videos what you have shown to us. And now I am requesting Professor Mahipal S. Sajdev, President All India Ophthalmological Society. We are really very much delighted to find here with us. So now we can start your presentation, and now the time is yours, sir. We have already introduced your CVs and everything to everybody, sir.
Thank you very much, Dr. Shams, and good evening, everyone. Professor Hussain, Professor Ahmed, Professor Mohammad Partha, it's a pleasure being here in the webinar for Bangladesh Ophthalmological Society. I'll be talking about posterior polar cataract. And in posterior polar cataract, my emphasis, because that is my preferred technique, would be on the femtolaser assisted cataract surgery. Now, when you're looking at a posterior polar cataract, this is a kind of a typical picture that you see of a posterior polar cataract on a slit lamp. Obviously, when we are looking at this, we need to be very careful as to the possible complications or the difficulties that we may have during the cataract surgery. And a detailed slit lamp examination will often give you a lot of information on regards to what the posterior polar cataract looks like. Now, when you're looking at an onion whirl appearance and you can actually at times see the defect, you need to be very, very careful. Now, the biggest problem in a posterior polar cataract is the pre-existing weakness in the posterior capsule. So various studies have reported various incidences of posterior capsular rent. That means that there is a pre-existing rupture in the posterior capsule, which could vary from anywhere between 10% to 35%. And that has been reported from various studies. Now, when you are doing a cortical cleaving hydrodissection, this can cause a hydraulic rupture of the posterior capsule. So the importance of a posterior polar cataract became more and more evident as phacoemulcification came, because once you have this, you could have a rupture of the posterior capsule, you can have a nucleus drop. Therefore, we have become more aware of it. Better techniques are now available, and therefore we want better outcomes that we have. Now, the femto laser assisted surgery gives you a very good pneumodelineation, which is there, and it could eliminate the need of hydrodissection or hydrodelineation. Also, the advantage of a femtolaser is that the femtolaser enhances nuclear disassembly, and you can even make concentric rings or segments that could simplify the nuclear removal. Now, when you are doing phacoemulcification, what are the important things that you need to keep in mind? See, the issue is that there could be a pre-existing posterior capsular rent, and therefore you want a very, very closed and a stable chamber. This is the most important thing that you need to have. The fluidics need to be as slow as possible, because if you are working at a high speed and your bottle height is high or your irrigation pressure is high, then the chances of a rupture of the posterior capsule becomes much higher. Now, the other important thing that has been shown by several studies, and Dr. Namrata is here, they're also working on it, is the use of an anterior segment OCT. So the slit lamp examination needs to be done well, and you need to use an anterior segment OCT during the surgery if you can have with the femtosecond laser. Now, what is very, very also important is that you should not have an error in doing the capsulorhexis. Now, often if there is a pre-existing rent, there is precious little that you can do. That rent is going to happen. And once that rent happens, if you have a perfect capsulorhexis, you can do a sulcus placement of the intraocular lens. So that is of utmost importance, that you should not have your rhexis run away. You should take care to make rhexis. Dr. Daljit Singh's group has been talking about an oval capsulorhexis, and that can also be done. Now, what is also very, very important, what is also very, very important is that you should not do a rotation of the nucleus. You should not do a forceful hydrodissection. If you have a polar cataract, the hydro procedure should be limited to a hydrodelineation so that you retain an epinuclear cushion and you have not rotated the backbone or the epinucleus of the cataract, because this can accentuate a rent. Now let me just show you what I am talking about as regards the OCT. If you can also get a good OCT, if you have a spectral domain OCT in the OPD, you can also use that, and I will show you images as regards the IOL master, also showing you some of these. Now, this is a system which is the catalyst system, and you just watch this particular area here. What is very, very clear is that it delineates the anterior and the posterior lens borders. So you can see that these are the lens borders that you have here. And you can see that this is the area which is going to be causing you a problem. So you can leave behind an epinuclear cushion so that you are above this area. So you need to do the dissection in this area, leaving behind this clear area. So the OCT image gives you a fantastic look at the capsule. So look here, this is what I'm trying to show you. This is the area where you can see the bubbles. And you can see that we have taken it up and we have done a nucleus emulsification only in the blue part. Now, this is therefore what I was talking to you was that the default setting which you have here can be raised so that you can leave this particular area and have about 1,000 micron of a cushion. Now, there are various studies to show the Chan and Lee et al. Have shown that application of anterior segment OCT can identify eyes with posterior polar cataract, and this can be done even pre-operatively. Also, there have been studies by Kimonos et al. Which have shown that anterior segment OCT can demonstrate good posterior capsular rents. Also, pre-operative OCT or optical coherence tomography is also being used by a lot of other people. So all that I'm trying to tell you is that if you have a good OCT and even an IOL Master 700, you can actually try and attempt to see whether there is a pre-existing rent or not. Now, if you look at this particular image that I'm going to show you, at this particular image, you can see that this is a photo essay. Now you can see that if I had done a good slit lamp examination, there is a huge preoperative rent. If you see on the IOL master, okay, in this OCT, you can see that even the IOL master is 700 is able to show you a clear-cut defect in the posterior capsule. Now, if I go on to the catalyst system, again, you could see that I can see a particular defect. And if you go on to the intraoperative OCT, where you can see that this is at the end, you have a rent which has happened, and you can see that a blob of vitreous is coming out of this particular area. So there are several ways that you can image whether there is a pre-existing rent or not. And once you have imaged that, you have to follow the guidelines that I have told you in my first slide as regards the phacoemulcification. Now, when you are applying the femto, the advantage of the femto incision is that the architecture is perfect and it will help you in maintaining a closed and a stable chamber with no fluctuations. As I told you, the second important thing after the low fluidics is that the capsular axis needs to be very good. And a capsular axis is a boon if things go all right, but it is a fantastic blessing if the things don't go well. That is that you can use the capsular axis to actually put the lens onto the capsular axis into the sulcus. Now, the next important thing is that when you are doing a nuclear softening, try to make small pieces, even if you are doing phacoemulcification or you are using a femto, and do not rotate the nucleus. Very important, do not rotate the nucleus, do not do a hydrodissection, work on low fluidics, and you should be able to get a good outcome. Now, in a femto, because there is already an emulsification that has happened, the nuclear rotation may not be needed at all. Now, Vasavada et al. Have said that even if you are looking at a femto or you are looking at a phaco, if you make these concentric rings, so supposing you are doing a phacoemulsification, you remove this central core and then you do a hydrodelination in situ using small amounts of fluid. Now, femtodelineation, if it has happened, it is better than a hydrodelination because it gives you sharp vertical cuts which are there and gives you a thick posterior offset. Now, this femtodelineation would virtually eliminate the need of any hydro procedures because there is a pneumodissection that has happened. One important thing, whether you are doing a phacoemulsification or you are doing a femto, is that epinucleus can be used as a shield, and this thick epinuclear layer acts as a shield for the weak PC from the mechanical and turbulent forces during surgery. This is something very, very important, that you should remove the epinucleus right at the end. Now, if you look at the advances that have been made in the management of a posterior polar cataract, the same group of Dr. Vasavada reported a 36% PCR rate when they were doing a phacoemulsification. But the moment they went on to the flags where they could get an image and a femtodelineation was there, the incidence of rents went down to 4%. And Dr. Titiar, Dr. Namrata Sharma has reported a 0% rent rate. That means that the incidence of rents went down significantly. So this is something very, very important, that a femto today is a treatment of choice for a polar cataract. Now let me just show you what I have been talking about. Just look at this. This is the locking of the patient interface or the liquid optic interface. Once you have this locking done, internal guidance scanning means the OCT has started. Now, once the OCT has started, just see that this is the anterior capsule. Now, you will see the posterior capsule and you can see a rent which is here. So, what I have to do is, I have to take up the offset. You can see that I have taken up the offset to prevent any nuclear disassembly at this particular point. Now, once we have done this, you can see that this is the capsulotomy which has happened. So, you are getting a perfect capsulorhexis. You are getting the emulsification of the nucleus. Just watch a fantastic capsulorhexis that you have got. Now, see, I will just remove the capsule because it is a fully free-floating capsulotomy and I have not used any fluid. There is no hydrodissection. There is no hydrodelination that is done. And it is only the pneumodissection that has happened, which is allowing me to take out the nuclear fragments very easily. So you can see that I have not rotated anything. You can see a thick plaque of the posterior polar cataract. Now just watch here. Hold this and scoop it out of the capsulorhexis. And now the last piece again, you can see that I am keeping the epinucleus intact and I have just removed the nucleus. And again, we are able to bring this out very well. And now watch, the epinucleus I am going to take out with the phaco probe. And if you are maintaining low fluidics, you can see that you don't get a rent even now. One important step that you are going to see here is that before I withdrew, I have injected viscoelastic. So it is a filled chamber that is there. And now I go on to remove the cortex. Now, once you are going on to remove the cortex, just watch here. The rent appears right at this moment. That means that I have been able to, you can see this, I have been able to postpone the appearance of the rent, which I knew right from the beginning that there is going to be a rent right after the last piece of the cortex has been removed. And you can see here that I am putting a 3-piece lens and we'll get a stable lens. Now let me show you. The battle is not one till it is actually won. So this is the photo essay that I showed you. I am prepared right from the beginning that this is a big rent. You can see that. Now we are again using the femto because as I told you, this is the procedure of choice. You can see here, this is the big defect that is there. You can see here. And what we are going to do at this particular defect, which you saw in the blue arrow, is to again lift up the default. So you can see that this default is being lifted up. And once this default has been lifted up, you will see that we can do, in this particular case, I am making 6 quadrants. I am making a capsulotomy And these are the 6 quadrants that have been made. A good capsulotomy has been done, and you can see this is a pre-existing rent. If you were not careful, you will have a problem. Now you can see the intraosity, and again you can make out that there is a rent. You can see here that this is the area. Now watch, no hydrodissection, no hydrodelineation. I have been able to remove all this very well. See here again, you can see that there is a rent which is showing you. You can see here, this is the rent which is there on the intraosity, and we will remove the cortex, as you can see. And as you are removing the cortex, you can see that the rent comes, and again I told you, inject viscoelastic before withdrawing the fluid. Now you can see that there is a vitreous block which is coming, but it is not broken. Now just watch, this is a lens which opened with a jerk. The moment it opened with a jerk, you can see that this rent increased. So it is very, very important that you do not open the lens with a jerk. And ideally, even if you have such a big rent, do not put the lens into the capsular bag and put it on in the sulcus. And just see what I have ended up in is that the nucleus is falling down. There was some vitreous that came in, so I have to now go back and try to remove the lens. I called my retina surgeon that this is sinking, but you can see that I was able to hold with a forceps. You can see with the left hand with the forceps, I was fortuitous enough to have the haptic held. So friends, I will just want to say that just at the moment you feel that all your tension is released, you can do a small little wrong step, the lens coming out with a jerk and extending the capsular tear that was there. I should have ideally gone in with a 3-piece lens, and you can see that I have to cut this lens, cut it only till the midline. You can see I am cutting it till the midline, holding the haptic. And now you can see that with half of it, hand over hand technique, you can actually remove the lens. Then we go ahead, do a vitrectomy, and now I am wise enough to put in a 3-piece lens. I was not able to see the capsular excess rim because the pupil had come down. So I have put 4 iris retractors to see that the capsular excess ring is intact, and you can see there is a huge rent. And we end up successfully in this particular case, despite the mishaps that we had. And just to have one suture, the patient did very well. The patient is 6/6 in vision, and we have planned for the second eye surgery now. So friends, what I wish to say is that the incidence of posterior capsular rent in a polar cataract has gone down significantly. It went down with phacoemulcification as compared to SICS, and with femtolaser assisted cataract surgery, it has gone down still further. So mind you, take the guiding principles into mind. Be careful whenever you are whenever you are handling a posterior polar cataract, and the outcomes will be nice for you. Thank you very much for your kind attention. Thank you.
Thank you very much, Professor Mohibal Shazib, for your nice presentation. I think now we can go on to the question answer session. Noman,
Yes, sir.
you have noted the questions,
Yes,
and we can
yes.
put the question to our speakers.
Yes. Thank you. Thank you, respected panelists and speakers. A lot of questions. Actually, I have collected it from the direct session and from the Facebook and different. Even also the people are doing personal SMS to us. So I want to start questions for Professor Jalal, sir. Here, for him, there are 2 questions. The first one is how will be the managed how will you manage the status of how will you manage the status of posterior capsule before doing the surgery? I think the doctor wants to know all about how can we assess the posterior capsular thickening or posterior capsular status being before doing the cataract surgery in case of hypermetro cataract.
Thank you, Dr. Noman, and they asking doctor, the good person, he want to know the status of posterior capsule.
Yes,
Actually, status of posterior capsule directly on slit lamp you cannot find with slit lamp. With OCT, you can see usually in white cataract. In posterior polar cataract, Professor Mohit says that has shown that how can we assess the status of posterior. But in white cataract, usually we are interested to see the status of the anterior capsule so that we can do a complete circular capsular axis. It's important. You can do a complete circular capsular axis, and the next step is easier. I think it is the answer of the question.
Thank you, sir.
Anyone can contribute?
Probably this question would be for the Mohibal Sahib, and because he has shown all these things for the posterior capsule, and OCT is a must for posterior polar cataract. So this question is for them, but I think Dr. Jalal has rightly mentioned that OCT is the only thing, not the slit lamp.
Can we mute our another mobile set or anything? Sir, some echoes are going on. So I have another question from one very special ophthalmologist. How will you manage the case of Argentinian flag sign during phacosurgery in case of hypermetropic cataract?
Thank you for your nice question. I have shown in the video that when Argentinian flag sign has occurred, you inject viscoelastic substances and complete the half part of the rexis, and then within that half part of the rexis, carefully do the phacoemulcification and don't go toward the radial extension area. You do your all the activities away from the radial extension area and carefully complete the phacoemulcification part. And after that, I have implanted the surgeon has implanted the lens in the bag also, so it is possible.
So,
video actually.
In that question, I think, Noman, in this question, if any of the panelists can add anything, they can.
Can I just
Yes. Yeah.
First, I must congratulate Professor Jalal for the excellent set of videos that he showed. Really wonderful. So, a very pertinent question this is asked, and about the phacoemulcification, the things that we need to keep in mind. And here I would like to express that Dr. Rohit Prakash described a flap motility sign. And this is a very, very important aspect, and which actually gives you an idea whether the runaway rexis is going back into the posterior capsule or not, whether it's going to cleave behind and cleave the posterior capsule as well and create a rupture. So the flap motility sign, most of us do know it, but in short, it is seeing the flap moving up and down on the irrigation while the phacoemulcification is going on. So as long as the flap end is mobile, that means that the extension has not taken place. The moment the flap dips down, that means that there has been a runoff the rexis into the posterior capsule. So at that point of time, phacoemulcification should stop and the nucleus management has to be taken course, so that understanding the fact that there is a posterior capsular rupture, which is possibly not being seen. So that is one small thing that I wanted to share with you about motility sign. The other small thing is, of course, carving out as much as rexis as possible with the help of the microforceps from the side port, so that the rexis is carved out and it is at least a semicircular rexis with the rexis runoff. And I think our analysts would agree that if a gentle phacoemulcification is done, even though we have an Argentinian flag sign, most often times the rupture does not extend into the posterior capsule, and you can get away with a good phacoemulcification and removal of the cortical matter as well as the nucleus, and placing the intraocular lens also in the bag against, of course, the axis in which the runout has taken place.
So, Professor Mohit, sir, will you please add something?
When you're looking at a white cataract, sorry, I missed part of Dr. Jalal's talk, so I really don't know whether what all he had covered. The most important thing in a white cataract is actually to get a capsular axis, a perfect capsular axis, and as Dr. Partha pointed out, even if you don't have 100% continuous capsular axis, even if you have it at 3/4 or 2/3 of the area, so you have to retrieve whatever has been lost. So even if you had an Argentinian flag sign, you can go ahead and do what has been described as an inverted T, and you can do the capsular axis from top as also from the bottom, so that you have a large enough area of the capsular axis. Now, the next thing that is going to decide whether you continue with the phacoemulcification or not is going to be the density of the nucleus. Often you can have cataracts which can be very hard with a white cataract. More often they are softish cataracts. So if you have a soft white cataract with an Argentinian flag sign, it is easy to handle that because you can actually levitate the nucleus out and do a phacoemulcification in the supracapsular area. But if you have a hard cataract, you will blow up the endothelium. So that is something which you have to decide whether you want to extend the incision and go on to an SICS, because that is the problem. And what Partha said regarding the flap motility sign, that is very, very important. The moment you feel that the Argentinian flag sign, if it has happened and there is an extension of the red posteriorly, now what is going to happen is that you can see a dip in the nucleus. You can have a decrease in the followability of the nucleus. You can have an irregularity in the pupil. You can have a peak or something coming towards the incision. So if any of these signs are happening, then please stop. And when you stop, you just put some viscoelastic. Do not come out with a jerk. That is something very, very important. And what one needs to do is that the surgeon needs to take a deep breath, hold himself, and then plan as to what has to be done, because there can be different approaches. The basic idea is to try to retrieve from the situation that you have. So that is something very, very important, that you should recognize a red at the earliest and try to retrieve the situation as things stand. More often than not, with the white cataracts, there is very little problem in the Argentinian flag sign, and he must have discussed the use of a small rexis and then increasing it, or having
all those videos are very beautifully shown.
Yeah. I think that is what I
Also, I think what you need to do is decrease your parameters as soon as it occurs. The flow rates go down, the vacuum should go down. So you work on lower parameters.
Thank you, sir. There is a question to Professor Partha Vishwas. First, microforceps you are using doing CCC in a subluxated lens.
Yeah. What microforceps is it?
Yes. What type of microforceps?
Well, these microforceps, initially I used the ones from MST, but our indigenous companies are making excellent microforceps in which actually the angle of the microforceps is very important. So the angle, it is an obtuse angle at the end, and the grip is nearly atraumatic. And I would like to go a little further from this is we do use the microforceps, and there is another special microforceps again made by our Indian company, which can actually hold the capsule while the other microforceps is carving out the capsular axis. That the counter traction is afforded by one microforceps and the rexis is made by the other microforceps. So both working in tandem can actually do off the microforceps with as less traumatically as possible, And microforceps always from the side port, so that there is no leakage of the viscoelastic while using the microforceps, or minimal.
Multiple microforceps is available, so it's quite good. Alternatively, if you don't have an ILM peeling forceps is good enough if that is available.
And if the CTR ring don't go in the bag, what can be the complications?
Okay, so I did not answer that question while I was showing my difficulty with that CTR ring. So when I looked back on this video a number of times after I had this problem with the CTR, so what was happening? What was happening is it was nearly a 270 degrees subluxation. meaning the whole nucleus was actually tilted. So when I was placing the CTR, instead of the CTR going horizontally, it was going nearly vertically. And that is why the end of the CTR was popping up and going and entangling into the side port instruments. So that was what was actually happening. So in such large cases of subluxation, what is important is to hold up the bag first, means to anchor the bag with the capsular hooks or even with the iris hooks, and then place the CTR, which I have not done.
Thank you, sir.
CONI would be a better idea for those patients with
Yeah, yes, because ultimately either
CONI would be better because segments, because then you would know where to anchor those segments.
yes.
Thank you. There is also some other our PG students. They are asking some questions to you. CONI rings and CTA rings. What are the indications actually?
Okay, so I showed that slide for the PGs only, the amount of subluxation that there is and when to use the CTR and when to use the CONI. Now we have the benefit of both these rings. It depends upon the surgeon's comfort which one uses, but the CTR is usually the first device that has to go in to stabilize a subluxated bag. So once that goes in, has an assessment of how much the subluxation is and to which quadrant should go the anchorage. So if the anchorage is there and only one anchorage is required, then the amid segments are quite nice and delicate segments which can anchor just one part, and that is all. However, as we saw in that spherophakic bag, so we use two anchorages and two amid segments. And in fact, in that particular spherophakia video, you would have noticed that the two amid segments were large enough to be placed in the bag and were encompassing nearly the whole of the bag. So a CTR was not actually used, and a CTR would be large, would be a lot too big to be used in the spherophakic bag. So,
thank you, sir. And
now the question to
any other-
Professor Amrita.
yes, lot of questions actually. What she has already answered. What is the preferred method of cataract surgery in the Fuchs uveitis syndrome and Fuchs corneal dystrophy and pterygium and cataract surgery, which should be done first, and how will you manage a post PK plus keratopathy? There are three questions.
When you're doing a phaco with pterygium surgery, then always you see what is the extent of the pterygium. If it is encroaching the visual axis and if it is more than 2.2 or more than 2 millimeters inside the limbus, then it is always best to do pterygium. But having said that, you should always also do a keratometry to see what is the astigmatism. And if there is significant amount of astigmatism that is there, then first always remove the pterygium, wait for 6 to 8 weeks, and then do the phacoemulcification surgery, because by that time the cornea keratometry would have stabilized. Maybe you can do it earlier also, say at around 4 weeks. As far as the Fuchs dystrophy with cataract is concerned, there are a lot of studies also which are available. Important thing is whether you can see visualization is good or not. If the visualization is poor, you will have to do a combined surgery. But if the visualization is good, then using a viscoelastic agent such as Viscode and good irrigating solutions such as BSS plus and using low parameters, you can still do a phacoemulcification surgery in these cases. See how it goes in the post-operative period, and you can defer a corneal transplantation procedure, which could be a DSEC or a DVAC graft, for as long as the cornea is clear. Sometimes even with 500 cells, the cornea remains clear and you don't have to do anything. But if the visualization is not good, the corneal thickness is increased, the endothelial cell count is low, which I told you, which is more than 650 microns of corneal thickness, less than 800 of cells, then and the visualization is poor, then in those cases you will have to do a combined procedure. What was the third question that you asked me?
How will you manage a case of postoperative bullous keratopathy? What is the
bullous keratopathy? Because after phaco, then there is no other choice but to do endothelial keratoplasty, which could be DSEC, Descemet stripping automated endothelial keratoplasty, or a DMEC, which is Descemet stripping endothelial keratoplasty. So those are the two options that you have.
Thank you. For the Professor Mahipal sir, there is a question. In solo practice, I think individual practice, one eye is posterior polar cataract and nuclear sclerosis, grade 1, and the other eye is white cataract. What should to do?
Okay, so basically, the issue is that if it is a posterior polar cataract in one eye, it is likely to be there in the other eye also.
Yes.
I would, if I'm doing a white cataract, it is very, very difficult to assess even with the OCT, the status of the posterior capsule. So under those circumstances, if you do not have a retina backup, first is that you should take a consent from the patient, which I always take, that there would be a requirement of a vitreoretinal surgery in case there is a drop. That is always written, and you should have the standby lenses. My thought process would be that in case there is a clear-cut posterior polar cataract and which you can visualize that possibly there is a rent in the first eye, in the immature cataract eye, then you should not handle it if you don't have a vitreoretinal backup, because there is a possibility of a drop. Or otherwise, if you want to be brave enough and you want to do that, then you should tell the patient that if a second surgery is required, I may have to refer you somewhere. So under those circumstances, you can put a suture. Do not panic because you want the patient and send to the vitreoretinal surgeon for backup. But doing one eye posterior polar, which is glaring at you, which you can see, and the other eye has become a mature cataract, do not do it under ideal circumstances without a VR backup and an informed consent.
Thank you, sir.
Dr. Noman, I have a question for Professor Mahipal. Hello.
Yes, sir.
Yes.
My question is that in polar cataract, if there is pre-existing navicular or big fusiform tear is there already, and when doing the surgery, when you take out the nucleus, you have to use all the low parameters, and you have to make this anterior chamber form using the viscoelastic. And when you place the sulcus fixated lens, and then what do you do with the viscoelastic already passed through to the posterior segment? Because if you keep the viscoelastic in the posterior segment, causing the postoperative raised intraocular pressures and a lot of other complications. So what do you do with this viscoelastic?
I think your question is valid. Under these circumstances, you can use actually not a dispersive, but you can use a cohesive viscoelastic that is there that will come out as a bolus. So that is one part of it. The second thing is, if you have to remove it more with an irrigation rather than a high fluid. So you can actually reduce the bottle light very significantly, go in bimanually, and you can just have somebody depress the main wound, or you have an irrigation coming in and let the viscoelastic flow out. There could be some viscoelastic that can fall back if you have a fusiform blend like I showed you. Under those circumstances, that absorbs over time, so there is nothing much that you can do about it. There can be some viscoelastic that can go down, but instead of doing a high like a viscoelastic, the normal setting that you have on the phacoemulcification, you should actually depend more on the irrigation, just the fluid going in and washing out the viscoelastic that can be done.
Thank you, sir.
Thank you.
Sir, another question. How do you do the cataract patient management in the COVID period?
Okay, so we have started our cataract surgery. In India, it is not mandatory to get a COVID pre-op either an RT-PCR or an antigen test done. But you can, if you want to be playing it safe, you can do that and not have the patient know the history and temperature, etc. Everything is taken. Now, the important things that the guidelines that were made by AIOS, which have been circulated, Dr. Namrata, Dr. Partha, all of them played a very important role in having these guidelines. The important thing that is there is that there was a fear that the phacoemulcification was an aerosol generating procedure. Now it has been shown that there are a couple of things if you do, there is almost no risk, or there is no risk for having the transmission. The first important thing is the use of povidone iodine. So codeine has to be put in the cul-de-sac. It is virucidal. And if you put that for a decent amount of time in the outpatient, as also like not in the outpatient, I mean before the patient goes into the OT, as also when the patient is being, after the patient has been draped, it is going to be virucidal. The second important thing is that always give the patient a mask when the patient is coming in, and the patient should continue to wear this mask. The third important thing that is there is that when you are entering the chamber, at that particular point, what is said is that the aqueous needs to flow out. So you can just put the infusion on for the phaco probe for about 8 to 10 seconds. So if at all there is any virus within the aqueous, that will get washed off, and then you can start your phacoemulcification. The other important things which have been shown are that if your incision is tight, the amount of aerosol generation is much lower. And what is also very, very important is that if you are putting viscoelastic methyl cellulose at the incision again and again after every 40 to 50 seconds, the aerosol generation goes down very significantly. So these are a couple of the things that you have to do. Obviously, there was a lot of this thing about the air handling unit and the AC, the doors being kept open. At least we are not doing that particular thing. We are using the normal air conditioning that is there, but we are doing surface disinfection after every case, and we are doing a fumigation every day. So that is something that we are doing. Touch wood, so far things have been all right. We have had 5-6 of our cases. Actually, 2 of them came out to be positive after the surgery has been done. So as we are talking, I have half my OT staff quarantined because of a VR surgery in which the patient tested positive. The patient is still asymptomatic, so one doesn't know. Today, there's a study that has been released from Delhi that more than 23 or 25% of the patients have antibodies that have been developed in Delhi. So I don't know to what extent the issue is, but so far there has been no transmission from cataract surgery per se of the COVID. So these are a couple of the things that you have to take care of while doing the surgery of phacoemulcification in COVID times. I don't know, Dr. Namrata, if
One thing I want to know. Yes, I want to know
Yes,
from
Dr.
Shahzeb and Namrata Sharma. One thing that each patient after surgery, how long or how much period you will make another one. That is, it will be done after 20 minutes or 30 minutes. Another thing, the AC of the OD temperature, how much you are keeping during the surgery.
Yes.
Yes.
Okay, see, we are not waiting for 20 minutes. The 20-minute wait is for a GA patient. So if you have done a patient because that is more aerosol generating, you have done the intumation, etc. Under those circumstances, you have to wait for 20 minutes. Otherwise, as I said, whatever time it takes, maybe 3, 4, 5 minutes for you to do a surface disinfection of the bed, of the surgeon's, not the surgeon, I mean the patient's bed. You can clean it with the hypochlorite solution, etc. Change the sheets and do the floor mopping. That's about what we are doing. There is nothing else in preference. Change the instruments for sure, but if you can change the phaco tip and handpiece, that is the other important thing that is there. I don't know what was the temperatures. I really don't know as to what exactly is the role. There was a lot of discussion that was there, and we have kept it open or loose from the AIOS perspective. We have even said that even if you are using a split AC or you are using an HVAC, it does not really matter. The temperature was supposed to be a little higher, maybe between 26 to 28 degrees or 29 degrees Celsius. That is what was recommended. Some people have talked about the UV light in the ducts, etc., but that none of us has been able to do. Somebody has talked about the air going out, etc., and have more airflow, but that needs structural changes, and we have really not done that. Because there was 1 or 2 studies or reports which said that people sitting in a restaurant with the same AC got the COVID. But the basic point is that if you are maintaining the hygiene of the patient vis-a-vis the masks are the most important thing. The masks are there, and then you have a drape on top of the face of the patient. So I don't think, and the other important thing, yes, I just wish to say is that we are also asking the patients to have gargling with 2.5% codeine iodine. So that is something which is commercially available, and even when I come back from work, I do that myself. So that is something that you can tell the patient to do the gargle before the patient is coming in to the OT. They can do it. The virucidal effect of that lasts for a couple of hours. That's what they say. So the patient can have that betadine gargle that can be done. I think if you follow these particular things should be all right.
So, sir, what mask you are using in the operation theater? Surgical mask or N95?
I am 62 years of age, so I am being a little more cautious, and that is causing me a lot of problem. I come back very exhausted after doing my ORs, etc. I actually wear 3 masks. So
Three masks.
I think 2 are sufficient.
Three.
You can,
I think 2 are sufficient. One triple laid and the other 95. That is
surgical mask on top of it. That's the 2 things that you can have. You can have double mask.
if you wear a double mask, triple laid for this, and then your N95, that is good enough. Another thing is for us, we are testing all the patients pre-operatively. If they are COVID negative, we are doing them. Otherwise, we are not doing them. And one important precaution is that the drape should be absolutely snugly fitting and should be tight so that there's no fluid which is, leaking out from anywhere which is coming on the drapes or on yourself, because fluid could be a source of virus. So it has to be absolutely tight so that there's no fluid which is going here and there. It's not spilling all over.
So we are using the E cover, and I put another like you have in the gynae ops ward. You have a cover to protect you from the blood. So we have those disposable ones which I put at the before starting to wash, and then on top of it have a disposable gown. So that is what. Then we have the. I always wear, even if I am wearing a zero power glasses, I'll prefer to wear that. But in the OPD, we are wearing the shield.
Protective shield. Eye protective shield can be given. PPE you are using in OPD?
No, we are not using PPE. I just wear the gown. Normally, I have the OT first and the so I carry the disposable gown, and after the OT, I just. Or you can have.
And so what about
but I have no.
With shield, it becomes very difficult to see on your slit lamp. Are you wearing a shield?
Either wear a shield or you have the big goggles on them, the scuba diving that you have. You can see them. That is there. You can use the.
We are also using the protective goggles, and sometimes face eye shield are being used, and also we have given the breath shield in the slit lamp. In this way,
one on the side of the patient and one on the side of the doctor.
Yes. Yes.
I think the patient needs to be masked, whether in the OPD or in the OT. In the OT also, I think all of us are masking the patients before they lie down, before they enter also for that.
Oh.
Give a fresh mask from your own
Yes.
side.
Fresh mask.
This is very important. Fresh mask.
Yes, Dr. Namita has said.
They are to remove their own. We will supply the new one to the patient.
Yes.
We have
I think,
we have a lot of questions. Actually, we don't have any time.
No, yes.
So,
We should
I'm
complete by
requesting all panelists to tell something.
Before going to panelists, I have one important question to Dr. Partho Vishwas.
Yes.
The question is, what things will we kept in mind to prevent subluxation of IOL in case of subluxated cataract?
Very important question, because that is the crux of the matter basically. So if the bag is well anchored, if the subluxation is well taken care of, if the lens is in the bag, and that would ensure that there would not be a subluxation post-operatively. However, if the bag is not well anchored, or the anchorage is not good enough, is not optimal, then there would be subluxation either anteriorly or posteriorly or to one side. So while tying the sutures of the segments, the MN segments, it is very important to keep it as optimal as possible. And if 2 segments are being tied, then between the 2 segments, the knots should be such that one knot is given, but the final knot is given just as it becomes in the optimal position. The lens and the back comes into the optimal position. These are a few small things that need to be kept in mind.
Sorry, I think this is the last question. This is from Sir Jalal Ahmed. The question is, do we have any means to judge the status of posterior capsule in white cataract?
This was answered because visibility is poor. In white cataract, visibility is very poor. Only we can see the anterior capsule. But if there is any subluxation, you can see that subluxation. But actually, directly posterior capsular status without examining in OCT, I think it is very difficult to assess the status of the posterior capsule.
The only thing that can be added is the UBM.
Yes.
So a
UBM.
little
Is available UBM? We can see that.
you could, yeah, possible.
Now, Noman, we can just hear from our panelists.
Yes, sir.
I will request Professor Hajrat Ali to say a few words and during our webinar, what you have noted. Professor Hajrat Ali.
Thank you very much. Can you hear me clearly?
Yes.
Yes.
Yes. Professor Sharfud, thank you very much for giving me the opportunity. Actually, all the four speakers are very much expert in their fields, in this field. So they have discussed and they shown the videos very nice and excellent. I have few comments in each lecture. Like this posterior polar cataract, during counseling, it is very important to counsel the patient that there may be chance of PCR, there may be long surgical time, and especially about amblyopia. And what I do during, or as the dehiscence occurs during the cortical removal, I try to stop I peel the cortex from the periphery and I stop before coming to the center. And almost when I am completing like this all the 360 degrees, then I pull the cortex from the center. This is the way I try to avoid the, or if there is a posterior capsular dehiscence there, at least there will be less chance of vitreous loss or the removal of the cortex will be very easy. Now the second is about the phacoemulcification haze. This is a big problem is coming in future. In future it means that we will not face this. Our new surgeons, younger surgeons will face this. There is a post-cross-linking patients and radial keratotomy patients and corneal illness patients, post-LASIK patients. These patients will come later on with corneal haze and cataract, and so they have to be expertise on this field to cope up in the new future. And with the corneal haze, the site of incision, you have to think about two things. One is where the opacity is, how dense it is, and number two, where is the thinning part of the cornea. If the opacity part is the thinnest, if it's thick, I don't worry to keep the incision near it. Or if it is thin, we have to avoid the thin part so that there is, during phaco there is no rupture or leakage. And Professor Phaco in loose granules, in younger patients, so we must rule out malformation and homocystinuria because these two cases may be life-threatening conditions. Because if malformation, there may be aortic dissection aneurysm, and in homocystinuria, there may be a thromboembolic phenomena. So even if there is loose granules or subluxated lens is there, younger, we have to rule out these two things. And about the white cataract, I think after this COVID time, this already 6 months we are not doing the surgeries, and maybe it will take more 6 months. there will be a big boom of white cataract surgery. Face a lot of white cataract surgeries with maybe with lens into glaucoma. So we have to master this white cataract surgery. I will thank everyone for giving the opportunity. Thank you very much.
Thank you, Professor Hazrat Ali, for your nice comment. Now the comment from Professor Din Muhammad Nurul Haq. I hope. Yes.
Can you?
Yes.
Can you
you
hear?
can hear. You can give your comment. Professor Din
Can you-
Muhammad Nurul Haq.
Can you hear me?
Yes.
Okay. So, Honorable President and respected panelists, learned speakers, and the dear participants from at home and abroad, a very good evening to everybody. Today, I am really delighted to be a participant in this wonderful Zoom meeting, being represented by the distinguished ophthalmologists from India and Bangladesh. I want to express my regards for my teacher, Professor Abba Hussain, and Indian Professor Mohibal S. Sasdev, my dear friend, Professor Hazrat Ali, for their precious international Zoom on different or difficult situations. My warm congratulations and sincere acknowledgement to all the speakers, namely Professor Mahibal S. Sasdev and Professor Partha Vishwas, Jalal Ahmed.
Lovely. Professor Din Muhammad Nurul Haq. You are asking. Yes. Yes.
Hello.
Yes. We can hear. You can continue.
Okay. So, you can hear me?
Yes. You continue.
Okay. So, and the dear participants, the traditional healthcare delivery model is gradually shifted to virtual healthcare model. By video and audio connectivity, we can organize video conference among the doctors, between the doctors and the patients at home. Through virtual meeting, we can connect any locations in the world. In pandemic crisis, this virtual meeting has become popular in almost in all professions. I can say that this is a good sign of the corona crisis. During COVID-19 pandemic, though it is difficult to organize a physical meeting, but virtually we are more connected globally with a stronger bonding. In every month, we are organizing international meeting, local meeting, online classes using this virtual media. Today, virtual session is unique of its kind. We are immensely benefited from all the presenters. All presenters seems to be quite healthy and physically fit in this stressful situation. Thanks to Almighty for allowing us to see our friends sitting in front of us. Our best wishes for all of them. Before I want to say few words. Phaco surgery for earology. Please stay phaco surgeon. Very safe phaco surgeon. Please develop a commitment in your mind to continue as a phaco surgeon in future. Have a exposure with many phaco experts with open mind. Complication-free surgery is never a guarantee in phaco. Important how a surgeon handles a complication. As the technology of phaco surgery is always advancing, try to do everything for precision and accuracy. Every phaco surgeon has to come across difficult phaco cases. Every case is manageable with proper knowledge, technique, and skillness. Management may vary from surgeon to surgeon. That is, one surgeon can develop his or her own technique they are comfortable with, keeping the basic principles same. All the participants in this webinar try to be successful and confident phacosurgeon and make an excellent career in the field of the phacosurgery. My gratitude and sincere thanks to President Wesby, Professor Sharfuddin Ahmed, and the Secretary General OSB, Professor M.A. Kader, and the today's moderator, Dr. Noman, for their excellent arrangement and for their capability of organizing this webinar on very important subjects. Thank you very much for patient hearing. May Almighty keep us in sound health in this corona crisis. Thank you very much.
Thank you. Thank you, Professor Din Muhammad Nurul Haq, for your nice comment. Now, our foreign panelists, Professor Namrata Sharma, do you like to have your comment? Professor Namrata Sharma, about one thing I want to mention, that the cataract backlog in this region, how we can reduce, you can give it in your comment.
So I think it is difficult to do that in the COVID times. As soon as the COVID times, get over, it will be cataract surgery will be faster. But having said this, during the COVID times, it is important that all the cases which are emergent or semi-emergent, like hypermature cataracts, white cataracts, they should be all addressed and they should be all taken up before other immature kind of cataracts. I think we have in India as well as in Bangladesh similar problem of having more of hypermature and mature cataracts. And like I think somebody said in one of the webinars, we are doing more mature cataracts now in the COVID times than we were ever doing before, because that is what we tend to address. We tend to address those kind of cases. So I think that is very important, so that the patients don't go blind. At this point in time, that should be our focus. And of course, as the times get better, focus should also be safety for yourself and for the patient. And as times get better, I'm sure the way we practice ophthalmology will change, but we will soon learn it. We are all learning it, and things and times will get better in the near future.
Now, it's time for Mohibal Shazdev, your comment. Along with this, I will just request you that along with this COVID period, the treatment, post-COVID area, the treatment of the patient, the academic activity, how you are running in our country, and is there any examinations of the postgraduate students or undergraduate students, how you are running? Along with your comment, please mention it.
Okay, so I think the COVID has thrown up a challenge for everybody, and normally the webinars or didactic teaching or the video presentations, etc., those kind of things can always happen, and they are happening at a much faster pace. As we started with webinars, I think the quality has improved, people have got used to it, and the attendance is increasing very significantly. So I think in our country, as also we are getting a lot of foreign participants, and as your society has also done, I think the globe has become flat, and we are getting people from all across the world participating in these webinars, and therefore the teaching from that perspective has gone up. The only problem which has been hit very severely is the actual patient surgical work and the patient examination, because you don't want to spend too much of time in the patient being in the OT or even in the OPD, and you wish to spend the least times of there used to be ward rounds and things like that, so they have been stopped. So yes, the fellows, the students, they are having time, and the only thing that we have been suggesting to them is that they should be looking at these videos, etc., and in addition they can try to set up a wet lab and try to do it on animal eyes, or if they have simulators which are far and few, so they should be working on those particular things to try and develop the skills that is there. But yes, it is going to be a tough time. I will really call it as a null year for a lot of the postgraduates and even for practices, I would call it as a null year, because this is the time when if you are able to stay alive and stay afloat, because there is a lot of financial implications that are happening because of the reduced turnovers all of us are seeing. And safety is important. We have had a couple of our people who have tested COVID positive and quarantine, those kind of things. But fortunately, all of them have come back. So, difficult times, at times you have to agree that it would be a washout, but we have to make the best use of that. So, we are also trying to get our people to innovate or to think of ideas, think of out of the box. There is going to be a new normal. We are ourselves trying to work on the tele-ophthalmology, and we have started tele-consultations and trying to help the patients even if they cannot come. Today also I did like 3 tele-consultations. Then we are trying to look at home care, delivery, etc. So you'll have to adapt to the new system, but the practical training of the postgraduates will be hit to some extent till this problem goes on.
Still in our country, we have not yet taken any examination. No postgraduate.
I can just tell you how we took our postgraduate examination at our center. So what we did was that they did a theory exam with social distancing. So the seats were placed far apart, and instead of doing it in one hall, which we used to do, we did it in 2-3 halls. As far as the practical exam was concerned, we had 30 students. All of them wore PPE for the practical exam, but there were no patients. So each one of us gave 10 questions, virtual questions, like patient having keratoconus. Then we gave a map with the color topography map which showed it. Then we asked, okay, what is the treatment? So the examiner, one of the examiners was from Delhi. So one of the examiners can be local, who actually came to the center for the exam, and the other examiner was again virtual from Chandigarh. So he was there only online. So all the short cases, long cases, vivas, grand viva, everything was done virtually on the laptop. The students.
So you have already started this examination online.
Yeah, our examination is already over. Students have degrees also given.
Okay, I think your academic section is being seen by Professor Parthovishas. I think OSB and the AIOS together we will have another webinar on postgraduate medical education in ophthalmology. If you permit, we will arrange through Noman will communicate with you. Very shortly, we will have another webinar on postgraduate education in ophthalmology, AIOS and OSB combined. Okay, before that, any comment from anyone? I will request our Professor Abha Hussain, who is the President-elect Asia Pacific Academy of Ophthalmology. Before his concluding remarks, I will request any panelist to add anything to our webinar today. If not, I will request Professor Abha Hussain to give his comment. Okay, Parthovishas.
So obviously, before Madam speaks, if I could have a chance to speak just a few words. Professor Maipal said that it is very challenging times, and he has said the right word, challenging times. But here I would go one step and say, it is a challenging time, but God has given us state leaders to meet this challenge. And had there been a lesser president for AIOS than Dr. Maipal, or a lesser person than Dr. Namrata Sharma at the helm of affairs, I do not think that AIOS and the AIOS body would have been able to do anything less than what we have done. So we are really thankful to God that the leadership is so strong, and they've all worked together to overcome these difficult times. And not only from the financial aspect, not only from the clinical aspect, AIOS has been able to reach out to the different strata of people who are dependent on AIOS, and that goes beyond the boundaries of India. And we've had the webinars along with the different countries, and we've been able to also project what we are doing in India, very India-centric, and what they can imbibe from India. And of course, we have imbibed so much of our learning from the countries who have already undergone the difficulties of COVID. But having said all this thing, we look forward to a very, very bright future. And we look beyond 2020, we look towards 2021. And Dr. Namrata, Dr. Professor Mahipal, all of them are working very hard to make 2021 a glamorous, a vibrant conference in the city of joy, and all minds and hearts are put together to make this a success. Because it's not only a conference for Calcutta or for West Bengal, it's actually a conference for Bangladesh and West Bengal for the whole unity, and that's where we are all there for. So 2021 has to be great. And with this, on behalf of AIOS, I would like to invite all of you to participate for 2021, which is going to be great.
Okay, thank you, Professor. We hope we will see there, not in webinar. You will see face to face.
Yes.
Now I will request Professor Abha Hussain.
Before madam.
Okay, Jalal will say something.
No, I
okay, Jalal.
nothing to
Jalal.
say. I have nothing to say, but I need to my gratitude to the organizers, to the panelists, to the foreign friends, and all the attendees for giving me the chance and for arranging such a good webinar. Thank you all.
Okay, thank you. Now we will hear from our guardian mentor, Professor Abha Hussain, who is the President-elect Asia Pacific Academy of Ophthalmology. She is our motherly guardian, Professor Abha Hussain.
Am I audible?
Not
Yes,
loudly.
Louder, ma'am, little bit louder.
Please, loud.
Ma'am, can't hear you.
Madam, we cannot hear you. We cannot hear.
Can't hear.
We
Now
can't hear.
Hello?
Yes, ma'am. Yes, ma'am.
It's okay.
Ma'am,
Please,
we
loud,
cannot hear
loud.
you. Madam, can you
We
please
can't hear. Madam,
raise you? Can you please increase your sound, ma'am, from the laptop?
probably laptop sound will be increased. You have to increase the sound. Madam?
She's out of the video.
Out of the video. She will come. Before her coming to our conference webinar, yes, madam? Can you hear me? No.
Can you hear
Madam?
me now?
Yes, ma'am.
Yes, you can talk loudly.
No, madam, we cannot
No,
hear
madam. We can't hear.
I think your earpiece is
Airport connection is lost.
Probably.
Hello?
Yes,
Yes,
ma'am.
Yes. You just yes, madam.
My heartfelt thanks to Professor Shafquati Ahmed, President OSB, and our Secretary General Professor Abdul Qadir. At the same time, my heartfelt thanks to Professor Mahipal and Professor Namrata, the Secretary, Honorary Secretary of AIO. Combination of Dr. Jalal Ahmed, Namrata, Mahipal,
He cannot be heard.
Ma'am, to take mic and speak on the mouth.
Yeah, you just keep it in front.
Hello.
Microphone in front, yeah.
Now it is okay.
Yes.
Yes. Okay, madam.
Type of white cataract and
Yes.
Phacoemulcification shows compromised tonus. That is also an excellent presentation. Namrata showed how haze is the cornea, and within that she is doing the Phacoemulcification and the posterior polar cataract by Professor Mahipal. Everything is very, very fine, but I will talk in some other aspect as it has already coming up, the academic, the education, everything. The postgraduate education. This is, of course, Professor Amrita said that they have taken distance maintaining the patient examination. But how it is possible? You have given the degree also, only without seeing the patient, no clinical, only theoretical, only lab, wet lab.
So, ma'am, for surgery, surgical videos, we did show them the surgical videos and take a
Yes,
surgical on it. Yeah, and for the cases, again, they were virtual cases. They were virtual cases, and the examiner selected them, the virtual cases, and the findings of the cases were asked for in the computer itself. The maps and all, anterior segment OCTs or posterior segment OCT or FA, again, the findings were asked in the virtually only. And not only we have taken the exam like this, but I think even in Delhi University, the exam is being taken out like this. All over the AIMS, I took one exam for AIMS Jodhpur. There also the format was same. Because it is not possible to, and of course, in that case, only thing that happens is that we have to
I
heavily depend on the
understand.
yeah, internal
Namrata,
assessment
I
of the
understand. But for the undergraduate students, we have in September, in our country, government will open all the educational institute, medical college, school, college, everything. But how it will be for undergraduate student? We have whose number? Not like 30-40.
They must be 200. But so I think you'll have to, ma'am, space them on different days. And like we had our 30 students, all of them wore PP. The examiners also wore PP. And they were adequately spaced, kept in one place. They were all kept adequate distancing. The exam took a little longer. Obviously, it has to take long because you have to, but it is very strenuous for the students to just sit in front of the laptop and keep answering because there is no, you go here and there, and those kind of breaks are not there, which are there in the physical exam. But that was the only way out. I mean, we have the whole module worked out. So if in case Bangladesh allows it, we can always share the module.
This is now it is from now onwards how we medical education real not only the medical but online teaching, not online teaching is going on. But after that, what we have expected will be starting to school boys and college students, they are coming, they will reside in the hostel, and for everything is very situation. So, not only we will be our student, for our postgraduate student, undergraduate student, and all this. And beside that, Professor Bin Mohammed here, Professor Jodali here, I miss their name, Dr. Noman here. So with all this, Noman is very active and he's always trying to organize the webinars. So recently, Professor Chakraborty told that I miss another webinar. In that webinar, I would like to request you, please just make a plan how we will, this COVID period will continue years later. 2020 is covered, but 2021 we don't know what will happen. We already have changed our EPO 2021 from March to August, and we don't know again then what will happen in August. So 2021 will also be in this period how we will continue. You are the giant person, you are giant surgeon. What you have shown today, everybody have benefited, including all of us here, but still but they have to do their own. So how this curriculum, how we can learn in the, I request both the president, both the secretary, he is a student, but all the doctors, all the trainers, all the president, I'm talking only the student, not student, but all type of varieties of student and trainees, everybody, how we can continue. So I think we will repeatedly we will be seen together and think all this as because we are thinking how we will continue the COVID lockdown period. Now it is running. My hospital day by day the patients are increasing, but still the consultants are also COVID affected. Employees are also COVID affected. Increased. Not compromised, but fight against this COVID and is something for our future generation. Thank you.
Thank you. Thank you, madam.
Thank you, madam. Thank you. Probably we are running about 3 hours together, both from India and Bangladesh. I think this is the time to conclude because if we want to arrange another webinar, we will complete by 2 hours in future. I hope the white cataract, subluxated or dislocated lens, and the corneal haze, phacoemulcification and polar. There are a lot of other different situations like aniridia, floppy iris syndrome, pseudo exfoliation. This will be also discussed later on. But today, I think excellent speech from our learned colleagues, Mohibal Shazdev, Namrata Sharma, Partho Bishwas, Dr. Jalal Ahmed, and the comment from our learned panelists, Professor Abha Hussain, Professor Din Mohammad Nurul Haq, Professor Hazrat Ali, and our moderator, Professor Kadir, the Secretary General of Ophthalmological Society of Bangladesh, and the last but not the least, he is the main man of this webinar, Dr. Shams Mohammad Noman. He organized very nicely. Today, we have already decided that another webinar on postgraduate medical education in ophthalmology, both in India and Bangladesh. I think, Noman, you will communicate with Partho Bishwas and we will make another webinar in August. With this, I think thanks to all the speakers who has given a lot of time for this webinar. Ophthalmological Society of Bangladesh is very much, I think, today honored by our Indian speakers and all India Ophthalmological Society.
Sharfuddin,
Yes.
hello?
Yes.
Sharfuddin,
Yes.
it should be the uninterrupted postgraduate education in COVID-19 crisis.
Yes.
The topic should be like that.
Make like this. Yes, we will make it like this. And I hope today we should not talk much more. You have given a lot of time to us, but you are with us, India, Bangladesh, together in a same webinar. And I think it's an excellent presentation, excellent webinar. Hope we will meet together even before meeting face to face. We will be in webinar before 2020 AIUS conference. Virtually,
Physically.
we will be, yes, virtually we will be together, and we have nothing to give you without the lab, because we will not be able to give you some foods, which is not possible virtually. With these three words, thank you very much, and we hope to see you again. Thank you very much.
Thank you, everyone.
Thank you very much.
Bye-bye.
Yes,
Thank you.
Thank you, Namrata ma'am. Thank you.
Yeah.
Thank you, Pastor.
Friends, thank you very much.
Thank you, madam.
Thank you. Thank you, Abba Madam.
Madam, Sayyid Muhammad Sahib, Hazrat Ali,
Thank you.
everyone.
Everybody, thank you.
Thank you.